Good morning, or good afternoon, or good evening. This is Dr. Murphy presenting a podcast on the brief history of double lumen tubes and why I use glycopyrrolate in thoracic anesthesia. The prime educational objectives of this podcast are for the learner to be able to recite a brief history of double lumen tubes in medicine and to explain the benefits and risks of routine anticholinergic use for lung isolation. The core reference for the thoracic rotation is Miller's textbook, 7th edition, chapter 59. This table is from a different textbook, but same authors, and it reviews the current indications for lung separation or lung isolation or one lung ventilation. And as you can see, they are thoracic surgery, surgery on the great vessels and heart and pericardium, esophageal surgery, non-thoracic surgical procedures, non-surgical procedures such as pulmonary lavage, and rarely differential lung ventilation. But first, let's delve into these double lumen tubes. The Carlens tube was developed in 1949 by Dr. Erik Carlens, a Swedish ear, nose, and throat specialist, and it was developed for bronchospirometry in awake patients in the days when tuberculosis was quite frequent. In the 1960s, Frank Robertshaw, a British anesthesiologist, invented his modification of the double lumen tube, the Carlens double lumen tube, which you notice has a carinal hook. That was in the 1960s. This is a photograph of a Carlens double lumen tube with a carinal hook. It's a left-sided tube, and the history of this tube was that Dr. Carlens invented it for separation of the lungs for bronchospirometry, and it was originally made of red rubber material, and it became commercially available in 3 sizes for large and small adults. The Carlens tube was actually only a left-sided tube, and the carinal hook was designed for securing its position. The tracheal part of the tube was oval in the horizontal plane, and both the tracheal and bronchial tubes had a D-shaped cross-section. The distal end of the tube had a cuff to seal the left mainstem bronchus. At the right side, closely above the carinal hook, there was an opening of the tracheal tube for ventilation of the right mainstem bronchus, and this was sealed by the inflation of the tracheal cuff. For bronchospirometry, Carlens inserted the double lumen tube under topical anesthesia in the sitting position. He placed a curved metal stylet into the bronchial lumen of the tube and tied the carinal hook to the tube with a moistened silk thread slip knot. After passing the tube through the laryngeal aperture under indirect mirror-guided laryngoscopy, he released the slip knot, withdrew the metal stylet, and advanced the tube into the left mainstem bronchus until he felt the hook engaging on the carina. The new Carlens double lumen tube offered advantages over single lumen bronchial tubes or a tracheal tube with a bronchial blocker for thoracic surgery. The anesthetist could control ventilation to each lung, including collapse of the operative lung, which enabled the development of new thoracic surgical techniques. The tube also provided for control of secretions and prevented spread of infected material from the diseased lung to the healthy lung. In 1952, Bjork and co-workers reported its use in 500 lung resections. The preferred technique using topical anesthesia and direct laryngoscopy in the awake state was the same originally described by Carlens for bronchospirometry. Less frequently, they inserted the tube after induction of general anesthesia using direct laryngoscopy, best performed with the curved Macintosh laryngoscope. So it sounds like this is one of the places where the use of a curved blade was first recommended. For left-sided pneumonectomy, the tube had to be withdrawn into the trachea before clamping and suture of the left mainstem bronchus. The carinal hook also hindered close resection of the right mainstem bronchus. This red rubber Carlens double lumen tube was manufactured by a company called Roche in Germany. The white double lumen tube is a right-sided tube with a carinal hook. The Robertshaw tube is still generally accepted to be the gold standard in double lumen tubes. The advantage of this design are that it's easier to insert than the plastic tubes, although you'll have to take my word for that. It does not soften on warming to body temperature like plastic tubes, and therefore holds its position better. The right sided tube has been demonstrated to have the best margin of error for ventilating the right upper lobe of all double lumen tubes. At least this is what's stated in the Benumof textbook that I've given you in previous podcasts. The red rubber cuffs may provide significantly better sealing to inhibit aspiration than plastic cuffs. Arguable, but this is a purported advantage of the good old red rubber tube, and it is sterilizable and reusable, which of course in this day and age is considered to be a detriment. As the slide indicates, a company in the United Kingdom makes 4 sizes of Robertshaw tubes now. This is a right-sided Robertshaw tube, has no carinal hook. It's, as of a few years ago, was still being produced in 4 sizes in Great Britain. And this is a photograph of a disposable rubber tube, also made in England, following the original Dr. Frank Robertshaw design. He's also credited with assigning the blue color to the bronchial cuff. B for blue, B for bronchial. This is our double lumen tube at the University of Kentucky, the Mallinckrodt BronchoCath. As you can see, it's patterned after the Robertshaw tube, and as you remember from previous podcasts, it was modified in 1994 and 2000 with respect to the angle of the bronchial part. As you can see, there's no stylet in this tube. So the BronchoCath is available in sizes ranging from 28 to 41, with and without CPAP systems from the factory, and it also is available in 35 to 41 with a carinal hook, which I've never seen. However, that's what's published. Another brand of double lumen tube is made by Sheridan or Hudson, and has many of the same features of the tube that you're used to, including depth marks, and if you notice, this one here has a tear-resistant cuff, which I've warned you about damaging the cuff on the insertion of the tube. This is a right-sided Sheridan tube called the right-sided Sherry Bronch. Has a larger eye for ventilating the right upper lobe. It is purported to have a unique double bronchial cuff, which you can see in the yellow box, and the manufacturer purports that this increases the margin of safety when positioning the tube in the right mainstem bronchus. Roche makes Robertshaw type tubes, a Carlens type and a white type, seen in these photographs. I think that you could agree that the tracheal cuff is fairly recognizable. Portex also makes a double lumen tube, and it looks like this. So, just to reiterate from a previous podcast, this cartoon shows the essential features of double lumen tubes, left and right, and this should be pretty much old hat to you now that you have reviewed a few podcasts and probably have had the opportunity to insert a double lumen tube. Now, what is this French stuff? So French comes from this man here who invented the unit of measure of Chaudière. 1 Chaudière is 0.333 millimeters. In other words, 3 Chaudière is equivalent to 1 millimeter. And this Cutler, in other words, he was an instrument maker, developed this this unit of measurement. And it's been carried over to many medical devices, and the double lumen tube of 39 French is exactly 13 millimeters, more or less, depending on the manufacturer and the tolerances for manufacturer. So that after that slight digression, let's go to glycopyrrolate. Why use glycopyrrolate? Why does Dr. Murphy use glycopyrrolate in all his thoracic cases? Well, over the years, and with literature review and inquisitiveness, I found a number of studies that support the use of glycopyrrolate, and I'm going to summarize them here for you. This one here is from the 1980s, and concludes that that glycopyrrolate and atropine have potential valuable adjunctive effects in patients undergoing anesthesia in whom reflex airway reactivity is likely, and in other words, in asthmatics, it was found that that airway resistance was decreased and bronchodilation was enhanced in normal patients, and this was carried forward to asthmatics. I do remember finding a reference on the use of atropine and the prevention of post-bronchoscopy hypoxemia in awake patients who underwent bronchoscopy, but I can't find it at this moment. Nonetheless, there are other studies. In 1998, a study that looks at the use of anticholinergics and the greater understanding of muscarinic receptors, concludes that vaguely mediated bronchoconstriction and hyperresponsiveness occurs following a antigenic challenge. In anesthesia literature, it was often stated that atropine was contraindicated in asthma because it would increase viscosity, and if you do a literature search on that, you really can't find any support for this statement. It seems as if anticholinergics like atropine and glycopyrrolate reduce the volume of secretions, but don't actually increase the viscosity as would have be predicted. Moving forward in time, with a greater understanding of the variety of muscarinic receptors, it was found and stated that muscarinic receptors in chronic obstructive pulmonary disease, if inhibited with anticholinergics, reduced airway secretions, etc. With parasympathetic cholinergic nerves providing the dominant autonomic control of airway, smooth muscle contraction, submucosal gland secretion, and also affecting vasodilation, it's concluded that in asthma and COPD, the activity of parasympathetic nerves is increased, leading to enhanced bronchoconstriction, mucus secretion, and vasodilation, and therefore the antagonism of those effects by the use of glycopyrrolate is beneficial. Pretty complex cartoon / diagram that seems to implicate viruses and ozone and insulin, etc. However, nonetheless, there is some pretty compelling evidence that muscarinic receptors and airway diseases go together. So, in anesthesia, what about glycopyrrolate? Well, here in 2000, Dr. Javier Campos and colleagues report that they administered, as part of the anesthesia, routinely administered glycopyrrolate in their patients who were being studied for the placement of one-sided, right-sided versus left-sided tubes. And also, in 2003, all patients received 0.3 milligrams per kilogram. In 2006, all patients received between 0.3 and 0.4 milligrams per kilogram. So either they're impressed with the routine use of glycopyrrolate, or they're not impressed with the low dose and have to keep increasing the dose. However, I think that my observation is that there's very little side effects. It's very little tachycardia with 0.2 or 0.3 milligrams. And if you want to achieve maximum anticholinergic effect, perhaps you do have to use 0.4 milligrams. This slide here shows a publication from 2004, so not that long ago, and it is an audit, a retrospective kind of study, so maybe of not the highest quality. However, it concludes that patients who are given antisialagogues are less likely to have desaturation. And outside of anesthesia, an interesting study that shows that glycopyrrolate causes prolonged bronchoprotection and bronchodilation in patients with asthma from 2005. And these authors concluded that there's a prolonged bronchodilator response and protection against methacholine-induced bronchospasm with inhaled racemic glycopyrrolate. And these authors, I think, are situated in Europe, and while the FDA doesn't support the use of inhaled or nebulized glycopyrrolate, I have injected glycopyrrolate in a somewhat diluted swirl into the airways in patients who have not responded to anything. And anecdotally, glycopyrrolate intratracheally does have an apparent bronchodilator effect. So, sum it up, there's some evidence over the last 30 years that glycopyrrolate is a bronchodilator. If you remember that atropine was a treatment for asthma many years ago, and if you think of the anticholinergic treatment of COPD, It's not too much of a stretch to make glycopyrrolate a routine drug for patients undergoing double lumen tube placement. This slide is a photograph of 3 right-sided tubes, the top tube being a Sheridan, the middle tube being a Rush, and the bottom tube being a Mallinckrodt. The next 2 slides will present when to use the right-sided double lumen tube. This one is from Miller's chapter, and the preferred right-sided double lumen tube is pretty much straightforward: left pneumonectomy, left mainstem bronchus surgery, perhaps the left upper lobe resection, and a single left lung transplantation. In addition, some authors suggest that a descending thoracic aneurysm compressing the left mainstem bronchus would be better served with a right-sided tube. Well, this concludes a 21.5-minute podcast, and I thank you for your attention and hope that the information presented will assist you in your clinical development and shorten your learning curve. Thank you very much.